Here we have a patient with a recent ACS. You can see that there is a very critical calcified stenosis in the proximal mid-right coronary artery. It's an anomalous vessel, so that was the reason why we decided on a multi-purpose catheter. The multi-purpose catheter is sitting very well aligned to the vessel wall. So the plan is, because it's a critical lesion, we thought that imaging should be done after the plaque modification. So our plan is to do plaque modification with orbital atherectomy and then do imaging to decide on what further has to be done, and then go ahead with stent implantation. We had a temporary pacemaker also in, because it was an ACS lesion. We might end up having a slow flow and AV block, so we had a temporary pacemaker in. So now during the orbital atherectomy, we saw some brady given atropine, ST mild ST uptake, but the BP is good with small dose of noradrenaline and after atropine. Okay, now we'll go ahead. There is some, is the guide catheter tip okay? To just take a blank cine. Just look at the guide catheter tip. It's okay, le? Okay, we'll go ahead. Slow it. Those calcified areas, we'll dwell more on that calcified areas, because beyond that there is an ectatic area. Even though the wall appears to be calcified, there is, the lumen is quite good. Yeah, we'll come back. Andy മാറിക്കോളും, ബുദ്ധിമുട്ട് മാറിക്കോളുവേ. We'll take a small cine. Guide and repush. You want to pull it back and then just pull it back. Andy കഴിഞ്ഞു, Andy കഴിയാറായി. Okay, that's it. Position is good. We'll do a cine. Okay, there is some slow flow, so probably we'll do exactly in that particular area. We'll do once again and then stop it. Get this necrorandil and SNP ready. That is the only area wherein we see calcification. Some more sedation. I think we'll stop. Entire balloon is enough. There doesn't appear to be calcification. Yeah, we'll take this out. We'll take this out and go with balloon dilatation and further. Okay, glidus is more. Break. Okay. Okay. Give us the regular workhorse wire. Balloon, 3 mm balloon. Okay. 3 mm balloon. We'll dilate it, give nicoran and SNP, noradrenaline, run through wire. BP is good, rate is good. How much of 0.1 midas? 0.1? Okay. No, midazolam, what is the dose? 1.5 midazolam, milligram midazolam, and 50 fentanyl. Another 50 more fentanyl we'll give. Okay. Now we'll take out the wiper wire. Somebody catch hold of the wiper wire. Okay. Now we'll do balloon dilatation and then balloon dilatation, and then we'll give some Nicoran and SNP. Now the ST segment seems to be better. (12, 14, 16) negative. Nicoran 2+2 and SNP to be ready, to be kept ready. Okay. And if the flow is bad, we'll need a aspiration catheter for the dilate. Pote, shall go up? 14, 16? No, it's melon seeded, negative. Okay, go up. 10, 12, 14, 16, negative. Okay, proximal. Go up. 14, 16, negative. It's melon seeded. Okay, 14, 16, 14, 16, 10, 12, 14, 16, 18, negative. Okay, again 14, 16. Okay, negative. That's it. We'll take it out. Okay, flow is better. Now we'll give Nicoran SNP, wait for the ST segment to settle down, and then do the rest of the procedure. Pressures are good. Nicoran SNP. Initiated tirofiban. Yeah, we'll start tirofiban. Give us some little bit of tirofiban intracoronary also. We are given 2 milligrams of Nicoran. The guide we'll keep the guide little more inside the coronary. Okay. Now sodium nitroprusside 100 mics. SNP 100. Saturation is good. Flush. And some tirofiban also. ST segment is slightly better now. See the ST segment, most of the time when we give tirofiban, the T waves tend to get inverted. Is it tirofiban alle? Either. See, the T waves are got. We're not sure because it's cold or whether tirofiban related this T inversion happened. Okay, T waves are better. Now we'll wait for the BP to improve and then do OCT. Okay, now what should be the plan like for the distal lesion? Shall we take one long stent and cover both the distal lesions? May not be possible. That appears, the whole vessel appears to be deceased. And it looks, all these things should be lipid plaque. It should be even, so that also is likely to be a vulnerable plaque down there. We'll do an OCT. We'll certainly do an OCT. Vishnu. Then we'll decide. Okay. Wire into the other brain. Okay. Just that's too small, Abraham. Okay, this seems to be okay. Now we'll go with the OCT catheter. ST is better. 20 cc syringe, it's ready. We'll do imaging twice, Vishnu. Initially, we'll evaluate the proximal lesion, because if you try to evaluate the distal lesion, the contrast clearance may not be. Primarily for whoever is not totally routinely used to OCT, this fisheye is basically to calibrate the catheter. So these dots actually should be on the catheter. The 4 dots, the green dots, at least 2 of them should be on the catheter, outer border of the catheter. So only if it's properly calibrated, the vessel size, when you assess it, will be proper. Otherwise, once you're not calibrated properly, then the vessel size assessment will be always erroneous. Oh, no, not distal. If it's going in easily, then we'll go assess the distal lesion first. If it's going easily. Okay, okay, okay. We'll keep it there. And that we'll make sure that the catheter is not totally into aorta and not deep into the coronary. Okay, that looks good. That area looks good. Now, here we are ready. The pressures are okay. ST segment is settled. Flow is okay. Now, yes, catheter is good. Auto calibrate. Vishnu, you are ready? You are ready. Here we are ready. Yes, auto calibrate. Enable. Activate. Okay, at least we got an idea regarding. We'll pull out here. Gonna flow is slow. We'll pull it out. Vishnu, into the, at least into the, we'll keep it there. We'll keep it there. The flow is better now. Okay. We'll take one more image and then not the osteal lesion. We'll take it once. We'll do one more imaging, take out the catheter and then evaluate the. Okay, then lesion kitty. But still we'll keep it there only. Okay, we'll keep it there. Okay, the guide should be positioned little more into the coronary. We'll take a second image and take out the catheter, imaging catheter. Okay, okay. Yes. Activate. Yes. Good. Okay, that's good. Vishnu, catheter, we'll take it out. Make sure that the pressures are okay. Co-registration. Okay. See, now we have evaluated only the proximal and mid lesion, not the distal lesion. So this is the second run, right? This is the second run. Okay. Accept. Okay. So this is the second run, and here we are beyond the lesion, beyond the second lesion. So that is where we are. Here the vessel looks very good. It appears to be a healthy vessel, and it's around 3.3 millimeter in size. Now, as we come proximally, that's the balloon related dissection. We are seeing the dissection. This is more of a fibrotic plaque. It is not a significantly lipid rich plaque. There is some calcium over here at 1 o'clock position, and as we come furthermore proximally, the balloon dissection is seen, and here you can see some lipid. These dark areas are likely to be lipid, but it's not a huge lipid pool plaque which is vulnerable or so. Anyway, it was a tight lesion. We have managed that. Now, as we come more proximally towards the proximal lesion, okay, so we'll go see the proximal lesion. Again, we do not see huge amount of calcification there in the proximal vessel. Only see, again we have seen multiple dissection. This is a nodule at 4 o'clock position, and I think this area at 9 o'clock position there has been some calcium removal. At 3 o'clock position also there has been some volume reduction. So that is probably the only area wherein this is probably a nodule there and some volume reduction here, some small volume reduction there. So that is what we have achieved. Again, it is very clearly seen this is probably a nodule that is protruding into the lumen and that's been shaved off. So at least some luminal gain has been achieved with the orbital device. No huge amount of calcification inside the vessel. So now anyway, I think even balloon dilatation seems to be reasonable. We can go ahead with stent implantation. Now regarding the proximal and mid lesion. Now we'll also have a look at the distal lesion in review. We'll go back to the previous image to see the distal lesion. Angiography registration, but it will be slow flow on. So now this is the area where we saw the distillation. It is more of a lipid plaque, Vishnu, because it looks quite dark. The image clearance was not all that good, but it looks a tight lesion, 1.5 millimeters square. The luminal area is small and it looks more of darkish lesion. So darkish lesion, most likely it's a lipid pool, lipid plaque. I think it's safer that we cover that one also. Shall we use 2 long stents to cover it? One from here, from this area from here till the proximal lesion. If we cover, it will be around 46. I think 146 should cover this till here, 48, and the next 48 from here to here, 248. We can stent. Huh? 3 short stents. So you mean 3 short stents would be enough, right? Huh? Yes. Ah. Yes. Okay, so we'll take a long 338. 338 and 3.538, and proximally we'll go for a 4 stent. Yeah, we wouldn't go too much into the ectatic segment. We'll take a short stent and proximally dilate. 330. In between that hugely ectatic area, probably we can leave it without stenting. Yeah, that seems to be reason. Pardon me? DCB is always a good option. We're not very confident enough and bold enough to do it. See, when you have a 3.5, just see the vessel, assess the vessel size also, the distal vessel, this should be 3.5. When you put in a 3.5 stent, how often do you see a restenosis? We hardly see in a 3.5 vessel properly deployed, we hardly see restenosis, right? DCB, there is always a chance that, again, yeah, if it were to be in a branch, certainly we would be happy putting in a DCB. Now, not very courageous enough to settle down with a DCB. That's the problem. See the amount of support that you get with this multi-purpose case. It never moves out. pressures. That is what is recommended. But in our experience, what we see is almost always the vessel size is little bigger than what you see on OCT. So what we try to do is, if we get a 3.25 vessel on OCT, we take a 3 stent, deploy it there, and post dilate it with a 3.5, not at very high pressures. This, what was the vessel size? Okay. See here, in this particular distal portion, the vessel size is around, that's the EL to EL. Vishnu, distally it's almost 3.5, Vishnu. We have gone with a 3 stent, right? 3 stent. We'll again recheck it somewhere here. The vessel size is, it's almost 3.5. It's with experience, you need to see. Here you are seeing, see what would be the lumen diameter over here. Lumen diameter here in a tight lesion, the lumen diameter will be, see, 2 millimeter. You'll end up having a 2.5 stent in the proximal vessel. It's at least 3. So we never rely on the lumen diameter, because the lumen basically depends on the plaque burden. If you have huge plaque burden, a 4.5 vessel will look as if the lumen is only 2.5. So it's definitely safe not to look at the lumen. It's always somehow at least think that this particular area would be the EL, even if it's a diffusely diseased vessel, because you get an idea, because calcium is seen not deep into the vessel. So when you have a calcified vessel, still you will understand, okay, that should be the EL. You will have to approximate and then find. And this area, this particular area near the proximal lesion, the vessel size is actually again 3.5. So the ectatic area should be much bigger. That we haven't picked in this. Yeah, it's co-registered. No, you have to have extra. They make you pay extra 20 lakhs or something like that. Yes. Now we'll assess this ectatic area also. Here, this particular area. There the lumen will be looking much bigger. And if you look at the EL to EL, it should be almost again 4. Proximal vessel should be 4. So proximal stent, we'll go with a 4 mm stent. Here it's 4.5. 418 or 423. We'll again reassess it and then decide on that. Vishnu, we have deployed 2 stents, right? And now it's a 3.5. 3.25, yes. There is no significant ST elevation. Mid segment, definitely we have 3.5 size there. We'll reduce noradrenaline. Now we'll go with a 4 stent, and then probably we'll take a 3.5 definitely for the before that. Shall we fix the, or we'll settle, we'll do post dilatation of the distal stent and then come back to proximal. In case we have some strut protruding into the aorta, we might find it difficult to get the next balloon in. So we'll somehow post dilate. Shall we take a small check shoot and see if the flow? There is little bit of small slow flow. We'll post dilate with 3.5, at least the proximal half of the stented segment, and then come to the proximal portion. Probably a 23 would be reasonable, Vishnu. We'll come till near the ostium, not protruding into the aorta. 23 not going into the ectatic segment also. 4 or 3.5, which is post dilated to 4. Anything is okay. Yeah, we'll avoid that. Train distal വേണ്ട വിഷ്ണു അവിടെ പോയി ചെറിയ pressures 10 12. We wouldn't go at very high pressures there because already we have some slow flow. That plaque has more of lipids, so then 12. Yes. Now beyond this, more proximally, we'll go at 14 at most. Yes. Probably we can pull out the wire little bit. Yeah. Negative. Now be ready with the next stent. Yes. $80. Okay. 423, right? 423 and 4 post dilatation balloon. ഇനി അതും കൂടെ അല്ലേ ഉള്ളൂ, നമുക്കിനിയുണ്ടോ? DS DS. Yes. We look at the distal landing zone and we'll see the image. 1 millimeter maybe guide pull back ചെയ്താൽ മതി, ബലൂൺ സ്റ്റെൻഡ് തൊടണ്ട. Ostium, right at the ostium. We'll position it right at the ostium. Anyway, we are not test. That looks okay. Sini? Shady will go up. 14, 10, 12, 14, 16. 4 NC. Yes. Negative. ആൻറ്റി കഴിയാറായി. Cherry test. Chedi 14, 14, 16, 18, 14, 16, 18. Yes, negative. Another 18, negative. Okay. Curve. 14, 16, 18. 18 is enough. Yeah. Now we'll have a nitro OCT and this case probably the learning point would be the guide catheter, choice of guide catheter. And again, if we had an early imaging done, probably we would have avoided orbital, because orbital hasn't done a lot of good for him, because there was only one area wherein we saw that significant sanding was done. Probably we could have dilated even that particular area without orbital. OCT catheter. ആൻറ്റി ബുദ്ധിമുട്ട് കുറഞ്ഞില്ലേ ജലജ ആൻറ്റി? സെഡേറ്റഡ്. ഓക്കെ. We'll see the proximal segment till the ostium. We'll take a survey mode 75 millimeter. We'll disengage the guide catheter. Yes. Okay, here we are ready. Maybe a 5 millimeter we can go in. You're ready there? We didn't have to do that. We didn't, because we took 2 New York OCT. Only when you're working with the Oxford OCT, you'll have to pull out the wire and pull. In the previous case, we did that. We had to do that. Activate. Very good. Well done. Here the stent is very well opposed. The luminal areas, we'll just wait for the lumen. Okay, luminal areas are quite good, 7.58 millimeter square in the distal portion. Here there is some little bit of plaque prolapse at 10 o'clock position, and as we come much more proximally, the stent is very well opposed. Reasonable lumens, 88 millimeter square, and as we are closer to that particular ectatic area, a couple of struts are not opposed well. Here again, even the ectatic area, the lumen is quite good. It's 6, 7, 8, 9 millimeter, 10, 12 millimeter square at that ectatic area. Yeah, the stent is positioned exactly where it has to be in the proximal stent. In the distal portion is very well positioned. It is again, the lumens are quite good, 10 millimeter square, and as we come proximally, it's around 8 millimeter, and as we come much more proximally into the aorta, we are almost till the aorta. Okay, we are into the guide catheter, but here again it is well opposed. The lumen is quite good. I think we stop. We'll take final shoot with nitro and then stop. Anyway, it's not hanging freely into the ectatic segment also. The ectatic segment, it's more than 5 millimeters square. The other one is 4 millimeters square.